Hello, I'm Kelly Tanner, and I'm a clinical researcher at Nationwide Children's Hospital in Columbus, Ohio. I'm thrilled to be presenting with my colleague, Victoria Baker today, and we'll be talking about implementing occupational therapy clinical practice guidelines in an outpatient pediatric hospital-based setting. Our objectives for today are that we first illustrate our division's system for knowledge translation. Next, describe the guideline development process very briefly for occupational therapy. And finally, describe how practice guidelines are implemented in our department. I'm going to get started by talking about our context just a little bit. Nationwide Children's Hospital in Columbus, Ohio was established in 1892. It's one of the country's largest not-for-profit freestanding pediatric healthcare networks. We provide care to more than 1 million patients annually, and we have nearly 12,000 hospital staff and 1,000 medical staff. We specifically work within the division of clinical therapies, and there are around 400 professionals who work in our division. And as you can see, we have a variety of different departments and disciplines with whom we work. Our focus for today's presentation is really on that outpatient developmental occupational therapy department. But we'll also describe a little bit about how our evidence-based practice and research program works across the whole division. This slide is not meant to be read, but we wanted to give you an overview of our organizational structure. The light blue boxes towards the middle of the slide are our program managers who represent various departments. And up here with the purple box with red around it, you'll see our evidence-based practice coordinators and clinical researchers who support all of these departments. We have discipline-specific evidence-based practice coordinators and clinical researchers, and many of us support multiple departments. Some of us support only one department, but it depends on the size of the department and how our disciplines are distributed across these different departments. We work closely with the program managers for each area, but we also report to the director of the division. So before we dive into how we implement practice guidelines, we first just wanted to describe our overall evidence-based practice, research, and quality improvement program. We've had an evidence-based practice and research program for many years and have really expanded on the work we've been able to do in the last decade or so. Across the department, in our division, we have knowledge brokers with dedicated FTE to support our knowledge translation work. And each of these knowledge brokers have a mix of clinical practice and time dedicated to this work. We work very closely with each other as evidence-based practice coordinators and clinical researchers, but just with the nature of our positions, we tend to be in charge of different knowledge mechanisms. So these are our knowledge mechanisms, and for all staff in our division, the expectation is that everyone must engage in knowledge translation or evidence-based practice of some kind. But this is based on each staff member's FTE, interests, personal goals, and departmental goals. We have a variety of different knowledge mechanisms that can both help engage staff members in various ways to answer their clinical questions and to affect change across our division. The mechanism is selected based on the clinical question and departmental priorities at the time. For example, our new hire learning track is one in which each new hire is provided resources to educate them on our current best practices and knowledge translation resources over their first year with us. And this is done via a self-paced virtual learning platform and direct support from our evidence-based practice coordinator. Our journal clubs take place at least once a quarter and dive into the literature to answer a current clinical question and start a discussion to improve both individual and small group understanding of best practices on that topic. Our clinical outcome groups are groups that systematically review literature, extract the best and most applicable clinical recommendations, and then develop local protocols, education, and resources for our staff, and also help implement departmental changes to help support uptake of this evidence-based information. Our independent EBP projects are typically focused on an individualized clinical question based on a very unique clinical population or specialty. These tend to be individually paced and scheduled and can often lead to competency or protocol development. I'm going to skip down to the bottom to our research mechanism. And this mechanism is selected when there's a high impact clinical question that comes up and there's a lack of available evidence. And this is supported by departmental goals to really dive into that question and generate some new research on that topic. Today, we're focusing on the two mechanisms that have check marks next to them, the Practice Guideline Implementation Group and the Quality Improvement Team. And as we continue to build our capacity and quality improvement work, we're finding a lot of parallels between these two and finding that we can leverage quality improvement tools and processes to help effectively implement our practice guidelines. However, not all quality improvement teams are focused on implementing a specific practice guideline, and our practice guideline groups do not always do pure quality improvement work. That's why they are delineated into two different types of groups. Again, this slide is not meant to be read, but we just wanted to share a snapshot of the specific deliverables that come out of this program. So this is just a screenshot of our publications and national, international, and state oral presentations that were completed across our entire division in 2021. So we've really been able to share a lot of the work that we do with a variety of audiences. So zooming in specifically to the Outpatient Developmental Occupational Therapy Department, this includes 8 sites located around our city with a total of 52 practitioners. And we see about 600 patients per week across all 8 of those sites. Before we talk about implementing practice guidelines within this department, we just wanted to pause here and give some context for how practice guidelines are developed, although I'm sure there may be similar content shared in other parts of this grand rounds. The process that we're most familiar with is the American Occupational Therapy Association's guideline development process. Although this can certainly vary across professional associations or even take place outside the context of professional associations, we think this is a pretty standard way of coming up with guidelines. So in general, there's a systematic review that is conducted to gather the best available evidence, and that information is then used by the same group of authors or some combination of them to come up with a practice guideline. And often a specific approach, such as grade, may be used to make these recommendations as clear as possible for frontline clinicians. In many cases, there are multiple systematic reviews that might go into developing a single practice guideline. And we will revisit a review like this and this specific graphic a little bit later. I'm now going to turn it over to my colleague, Victoria, to discuss how we implement practice guidelines at NCH.
Thank you, Kelly. So as Kelly mentioned, my name is Victoria Baker. I am the evidence-based practice coordinator for our developmental occupational therapy team. And I want to talk to you a little bit about our formalized plan that we've created to implement practice guidelines here at Nationwide Children's Hospital. So this process has evolved over the years and has developed as we've gained some insight on what best meets the needs of our practitioners, what best matches the nature of the guideline itself, and what best aligns with our hospital and department's mission and vision. So we've begun to integrate quality improvement tools as well into this process, and we continue to develop methods for collecting data and tracking outcomes of implementation for practice guidelines. So here's how we began to conceptualize this process working from the beginning. We started with some initial education just to build some awareness that there is a new practice guideline out there and on a particular topic. Then we typically this all took place at an all-staff meeting where people were able to generate some discussions, and we were really able to gauge who might be willing to serve as peer coaches for this project. Next, we surveyed the team to see what the needs were to help support people in implementing these practices. Then those peer coaches would develop targeted resources to support those individualized needs that we identified. We then would have a big rollout of materials, which consisted of 3 things: education modules on specific topics, evaluation and outcome measure supports, and electronic medical record changes to support our practice. Finally, the peer coaches provided ongoing support to the therapists at their specific sites in person and across sites using email groups. So the first iteration of all of this was in 2016 when we started to implement the Autism Spectrum Disorder Practice Guidelines. So we learned a lot from this one, and our amazing group of practitioners really helped to shape the process that I just shared with you on the previous slide, and put into place a lot of systems that have continued to serve us well with each of those steps. Of specific note, this team really identified that electronic medical record supports are critical in implementing the documentation changes, and also identifying the need for peer coaches across our multiple clinical sites to support the ongoing implementation of practice guidelines are really important. So the second iteration took place in 2019 when we implemented the mental health for children and youth practice guideline. And for this one, we found that this was an area of implementation that we really had to draw on external resources for. So this included working with our inpatient partners on opening our lines of communication and creating warm handoffs for our patients. And those inpatient practitioners also had very specific skill sets that we were able to draw upon to spread some of their resources throughout our outpatient department, which was really great. We also spent a lot of time developing resources for community referrals within this practice guideline. So currently, we are now on our 3rd iteration of implementing practice guidelines, and we are working on AOTA's Birth to 5 practice guideline. As Kelly mentioned before, when you saw this graphic earlier, there are often many systematic reviews that will go into developing a practice guideline, which is the case here with this practice guideline specifically. So for this practice guideline, AOTA utilized 3 systematic reviews and 4 critically appraised topics to outline the guideline for the birth to 5 population in 4 different areas. So activities of daily living, rest and sleep, mental health, motor performance, and cognitive performance. Kelly had the chance of being a part of the team developing one of these systematic reviews and found it to be a really great learning experience and opportunity to work collaboratively with experts in the field to be able to generate this end product for a guideline that practitioners can really use to help guide their practice and select evidence-based interventions. So to implement this practice guideline, we've adapted our processes and procedures because of the nature of this guideline being so comprehensive, but also because of the COVID-19 pandemic, as I'm sure you could guess. So initially, education was done through discussing this practice guideline in general between knowledge brokers. And we really determined that several of the components of the Birth to 5 practice guideline were being addressed through different projects that were ongoing, and that we could pull this practice guideline into those projects to assure alignment through each of those. So with this in mind, you can see here the different stages that we're at with each of those 4 components that are a part of this practice guideline. So we've not yet started to implement the process with the mental health topic at this time, and we plan to do so as we start to wrap up some of the other ongoing projects. It's planned to have our peer coaches review the mental health Birth to 5 practice guidelines section and our previous work with our mental health rollout to assure alignment and make any updates as needed. For the activities of daily living, rest and sleep, we're initially educating our staff through journal clubs and quick clinical references that we're going to provide for them. And for the cognitive performance topic, we are currently surveying our staff right now, seeing what those needs are to support that area. And we're also working on developing some materials through handouts and some different things that we're going to provide to both clinicians and families. For the motor performance topic, we are continuing to support the implementation of these recommendations through our ongoing parent coaching project that focuses on motor performance in clients with cerebral palsy. So with the project being ongoing, we are implementing several different things over the course of time and kind of simultaneously as well, which makes this implementation process really unique. We're focusing more heavily as well on employing quality improvement tools to progress knowledge translation throughout this process. So now that we've discussed where we've been with practice guideline implementation process, Kelly is now going to talk to you a little bit about where we want to go as we move forward.
Thanks, Victoria. So as we've learned a lot that Victoria described over these multiple iterations of implementing practice guidelines, we've identified some areas for continued improvement and some future directions. So first, we're working on improving our data collection so that we can better capture the results of our implementation work. This is for two reasons. The first is that we want to make sure that we're capturing how we're implementing these best practices, and also so that we can look at patient outcomes. We're working on developing more discrete values in our electronic medical record so that we can more easily pull chart audits to determine how we're doing in certain areas. And we're also working on identifying integrated standardized outcome measures for each of our patient populations that we're focusing on. And this is really all in an effort, as Victoria mentioned, to build our quality improvement capacity. We want to be able to track patient populations over time as we implement these practice guidelines so that we can measure if our implementation efforts are reaching that patient level. And we also want to speak the same language as our referring providers as we work with them on some of these initiatives. So as we work on integrating these quality improvement tools, I just wanted to highlight a few specific ways that we're doing that. Our hospital uses the IHI model, the Institute for Healthcare Improvement. So that is where some of these terms are coming from. But in terms of identifying our peer coaches, we're working on identifying those initial folks that are really interested in the topic as our core team, and then thinking about how we can spread this to all 8 of our sites by identifying additional peer coaches that might be interested in participating. When we're identifying the needs of our staff members, we can use tools like a SWOT analysis, key driver diagram, and even baseline data collection to get an idea of where we are. As we're developing materials, we're focusing more on opt-out electronic medical record supports. So we're building in all of those reminders that a clinician would need to document their best practice. And we're also integrating with our existing departmental chart audits so that we can ensure there's follow through across all areas. As we roll out our materials, we're using plan, do, study, act cycles to look at the results of our implementation. And we're collecting data as we go to see how we're doing. We're also continuing that data collection to sustain as we provide continuing support to our clinicians. We thank you so much for your attention today, and we look forward to discussing our work further with you. Here are our references.